four major questions we have to ask about ventilators are the following. The type. The first thing is, what type of ventilation am I going to use on this patient? There are two types of ventilation. There is volume
and pressure.
Yeah, volume and pressure. This is also known as volume controlled ventilation and pressure controlled ventilation. So the way that this works is if I set a certain volume, so if I set a volume of 500 milliliters into the ventilator will administer breath until what? Until it delivers 500 milliliters of air into the patient, and then it stops, it cycles off. Does that make sense? Mm-hmm. What do you think pressure-controlled ventilation does? Instead of setting a volume, you set a PIP, a peak inspiratory pressure. So let's just say that I set my PIP at 20 centimeters of water. What do you think the ventilator is going to do?
It's
going to deliver breath until it hits 20 centimeters and then it cycles off. Does that make sense? So in volume control ventilation, I set a tidal volume into the ventilator, right? This is a tidal volume outline. And then in pressure control, I set my peak inspiratory pressure. So what do I not have direct control of in volume control?
Pressure.
I do not have control of pressure. What do I not have direct control of in pressure control? Volume. So what do you think I need to monitor closely in volume control?
Pressure.
Pressure, my PIP. And what do I need to monitor closely in pressure control?
Volume.
Make sense?
Mm-hmm. Why don't you invent something that you can do both?
There is. Yeah, there are what we call hybrid modes. Volume control plus, and so on and so forth. But these are like just the basic, nuts and bolts down here moves. Or typewriter. You guys good with that? So most adult patients do okay on volume control. Generally, we'll start with volume control. Pediatric patients, neonates, and patients that you're really worried about airway pressures, and you really want to limit the pressure in the airways, you want to have direct control of that, pressure control is generally where to go. But as a rule of thumb, we do volume control. Now, the next thing that we have to talk about is the mode of ventilation. And the mode of ventilation is how the ventilator and the patient interact. How do they talk to each other? So, if my patient is completely unresponsive and apneic. Does mode matter?
No.
Doesn't matter a damn bit. As long as it's a mode that can provide full support. Is that everybody okay there? Only time mode matters is when I have a patient that's actually taking spontaneous breaths and interacting with the ventilator. So I have three major modes. I have what's known as CMV, that is controlled mechanical ventilation. And I like to think of modes as kind of like a marriage, if you will. Okay, when you first get married, everything's really happy and you're talking and you're communicating really well. And then the further on in the marriage goes, the worse things go down. They go down. No, not always, but we'll just say. All right, that's CMV. CMV is basically headed to divorce. You want to look at it that way. CMV is where the ventilator has complete control over that patient. Okay, so if I'm in volume control ventilation, and I set a volume of 500 milliliters per breath, 10 breaths per minute. What is that ventilator going to do in CMV?
Give it 10 breaths at 500 milliliters.
It's going to give my patient 10 breaths, 500 breaths. What if my patient wants a bigger breath?
Doesn't get it.
What if my patient wants more breaths? What if it's too much, less breaths? No interaction whatsoever. Okay, that's controlled mechanical ventilation. Now, a step up from CMV is something known as AC, or assist control. Now, assist control is the only difference between AC and CMV is the following. In assist control, if the patient attempts to take a breath, so the ventilator senses if the patient's attempting to take a breath, the ventilator will deliver breath to the patient. What kind of breath will the ventilator deliver?
The
preset breath. So there's a little more interaction going on here. Does that make sense? And then finally, we move to the most interactive mode, SIMV, synchronized intermittent mandatory ventilation. And in SIMV ventilation, the ventilator senses that the patient's trying to take a breath, and what does it do?
Helps it.
Does it necessarily even help the patient?
No,
It just allows the patient to take a spontaneous breath. So that's that. Does that kind of make sense there? Yes, sir.
But I mean, you still, on the SIMV, you still set rate and volume, and then if you want to take an extra breath, it allows you?
Yes, you have a backup. You have your backup rate and volume. And then whatever the patient does above the ventilator, it lets the patient do it. So here's the question. What mode is best?
SIMV. I'd say AC.
Depends.
Completely.
Depends. If you have a patient that does not have an underlying respiratory problem, they have healthy lungs, SIMV might be a decent mode for them, right? Because they're not in any distress, they're not having difficulty breathing. Like, let's say somebody had a burned airway. Okay, they have an inhalation injury, their airway's burned, and you intubated them because you were afraid of their airway closing up. Well, are their lungs necessarily damaged? No. Is their brain damaged? No. So they may be awake, they may be alert, they may be taking spontaneous breaths. They're probably going to be more comfortable in a mode like SIMV. But let's say that I have a patient in severe respiratory distress, like a COPD exacerbation, and you intubated them. Do you think putting them in a mode that's going to make them take spontaneous breaths will be all that helpful? No, because why do we intubate them? Because they're not breathing effectively, right? So you probably would want to go with something like assist control in your more critical patients with these breathing patterns that need support. Because the ventilator senses that when the patient's trying to take a breath, and it says, here, I'm going to give you this breath so you don't have to work to take it. Does that make sense? And CMV is really only if you have an unresponsive apneic patient that isn't interacting at all. You guys good with that? All right. That's my mode. These are my settings. The next thing. So the basic settings that we talk about, if you're in volume control ventilation, your tidal volume, okay, your tidal volume, the flow of air, that's how fast air flows in and out. All right. Something known as the I to E ratio. Have you guys ever heard of that?
No.
Inspiratory to expiratory ratio?
Inspiratory to expiratory ratio. So that's the amount of time I spend inhaling and the amount of time I spend exhaling. What do you think a normal ratio would be, more or less, if you had to think about it?
1 to 5.
1 to 2, yeah. 1 to 2 is a pretty normal. So I spend 1 part of my time inhaling and 2 parts of my time exhaling. Does that make sense? And that's about right. You need about twice the amount of time to exhale as you know. Now, if you have a COPD patient or a patient with obstructive pathology, what might you need to do that I to ratio? You might need to make it longer, 1 to 3, 1 to 4, 1 to 5, to allow for prolonged exhalation, prolonged expiratory phase. PEEP, what is PEEP? Peak index expiratory pressure. It's pressure that is still in there, even at the end of exhalation. Why would you want to have pressure still present at the end of exhalation?
You don't want to set up
Yeah, you
atelectasis.
guys know this stuff. To keep the alveoli open, prevent them from collapsing, and to help oxygenate my patient. PEEP is basically CPAP, if you want to think of it that way. It's just CPAP on an intubated patient where you have them in some control mode. Does that make sense? It's pressure that's always there. It's pressure that's always present. Okay, now if I have my patient in pressure control, pretty much the only change that I make with this ventilator in particular is, do I have a tidal volume that I can set?
No.
No, instead I have a PIP. Instead of PIP. All right, and then my alarms. So basically what you'll do is you'll put your volume or pressure, you'll set your mode, you put your settings in, you'll start ventilating your patient, you'll see where your patient's at, and then you'll set your alarms based on that. One of the most important alarms is going to be the high
Low.
and low pressure alarm. And if you had to guess which one of these two is even going to be really the most critical.
High.
Low.
Low. Huh?
Low. Because that's the one that tells you that the tube gets pulled, the tubing gets disconnected, you run out of oxygen. Although this ventilator will continue to work on room air just fine. It just won't deliver anything greater than room air oxygen. The low pressure alarm, because that's the one that will kill your patient, right? If your patient gets disconnected from the ventilator, you want to know about it. Does that kind of make sense? You guys okay with that?
Yes.
High pressure is very important as well, because particularly if you're in volume control, right? Because you want to know if the pressures in the airway are too high. And as a general rule of thumb, pressures higher than about 30 to 35 centimeters of water are going to be problematic. You'd be concerned if your pressures are consistently higher than that. Okay, that's your crash course. You guys okay there? So what I'm going to do is I'm just going to take you through a basic setup on this ventilator here.